You all know why we're here, but I just love this chart. I think it really exemplifies why there's such a present need for us to be educating medical students about single payer healthcare and about the healthcare system that they're walking into. As you can see, we've got the US at the very bottom right with extremely high healthcare spending and very low health system performance. Now, I don't know how many medical students you've talked to recently, but most of us want to do a good job and have high performance when we enter our careers. And it's impossible to do that when the system is working against you at every nook and cranny. So this is just one of the charts that I think really exemplifies that. But as I said, our medical school has had a SNAP chapter, which is, like I said, the student version of Physicians for a National Health Program historically, and it's been very strong. But there just sometimes are bumps in the road and transition challenges, and I don't think that they hosted any events last year. So we're working to try to rebuild the SNAP chapter here in the Twin Cities campus, and Max is going to talk to us at the end of today about some events that are happening at the Duluth campus, which is really awesome. Our goal is to prioritize reaching first and second year medical students with this club because we want this to last for the foreseeable future. Obviously, we're still inviting older students, but we're really trying to connect with people who are going to be on campus for the foreseeable future and can continue to build up our student group. And one of the things that I struggle with sometimes when I go to education sessions or listening sessions on campus is I want to be able to do something at these meetings. I want to feel like I've had an immediate impact, even if it's small. So, a key theme that I tried to think about in coordinating the on-campus activities that we're going to do for SNAP this fall is immediate action. And I'll talk to you a little bit more about that when we get to the meetings. So where do we start? We start with the medical org fair, which already happened. And I'll talk a little bit about how that outreach and engagement went. We have our first formal event happening for those who are familiar with calendars this week, October 2nd. And we're going to be doing a little bit of a single payer 101. And then this November, Senator John Marty and Senator Dr. Alice Mann are coming to speak to medical students on our behalf. And I'll talk about each of these events kind of one by one. So there's me at the medical school org fair. There's the board that people saw when they were walking around the medical school org fair. The whole idea is just getting our image out there for the very first time in a little bit. A lot of people didn't know we had a SNAP chapter. They didn't know what single payer was when I spoke to them. We actually had 14 signups on that day for our October 2nd event. But the thing that really stood out to me was we had 8 people who signed up for the student board. They wanted to come and plan meetings and be really connected with the cause immediately. I think eight's a lot. I think that's pretty great. So 4 first year and 4 second year medical students are going to be more involved in the planning of our future events moving forward because they want to spend time advocating for this cause, and they just are putting their all into it like we did this summer. I find that very exciting. I've already connected with so many people that are going to be great allies for us. So what's happening on October 2nd? We've already got over doubled the amount of RSVPs for that. Thank you, PNHP, for providing pizza for us. I think we might be at 30 RSVPs for October 2nd now, which is just awesome. That's a pretty big chunk of people. We're going to start. We've actually got a first year medical student that I spoke with. He's going to be taking us through what single payer 101 looks like in the beginning. He was so excited after the org fair that he wanted to get involved immediately. And so he's going to be taking us through the first kind of 20 minutes of the session, teaching folks about what our current healthcare system looks like. And then I'm going to talk a little bit about single payer, introduce Marty's bill, and we're also going to have a closing action item, which I'm very excited about on Thursday. So I'm bringing in another student, a third year student named Hallie Vanny. She has been very hard at work trying to expand the actual University of Minnesota healthcare coverage for students. Something that I didn't know until I spoke with her is that it's actually really limited. And she's been having a really difficult time getting coverage for her specialty medications as a student here. And in that process has learned how many flaws there are with our healthcare system here on campus. Now, obviously, our goal in the long term is single payer. But in the meantime, I think our goals are still shared about expanding coverage, expanding access for people. And this feels like a really immediate action item that we're going to be able to do on Thursday. She's going to talk to us at the end of the meeting on Thursday, explain a little bit about her story, talk about the out-of-pocket costs and the restrictive coverage that she's been able to unveil Um, and then we're going to do some action items and do some on-campus activism for her. I spoke with her just the other day. We're basically going to be recommunicating her messages in a lot of different group chats and channels so that the message gets out. And we're also going to be emailing different people that are a part of the medical school in the University of Minnesota, which can be pretty effective. One bullet point I skipped over because I wanted to talk about it here is that earlier this summer, we connected with Hallie and signed a letter and sent it to administration demanding more equitable student insurance. She got a bunch of clubs to do that. We sent it to the dean of the medical school dean of DEI, a whole lot of people who we wanted to hear this message. And she actually had some really important meetings with some really high up in the process, in the food chain people. And she's starting to get some breakthroughs there. So we kind of want to keep that momentum going, and that's going to be our action item on Thursday, which I just find it really exciting that we're able to overlap with other people doing other really important advocacy goals. And then in November, we're going to bring Senator Marty and Senator Dr. Mann to campus. So I reached out to them a long time ago. Their schedules are kind of hectic. We don't have a November date set yet. But one of the things that's kind of funny is when I emailed Dr. Mann, she was like, I already heard from you guys. I'm already coming to campus. And I said, I haven't emailed you yet. And apparently, another group on campus called Medical Students for Healthcare Reform had contacted her and asked her to come to campus. And I thought, what a great opportunity for us to collaborate and find 6 to 8 new committed students who want healthcare reform and bring them into a larger cause like the one that we're working on right now. So we're actually going to jointly host this event for Senator Marty and Senator Dr. Mann with another student advocacy group that cares deeply about reforming healthcare. I think the main theme from this session, which we are currently working on, is that we don't need to wait for the national government to take up single payer. We're going to make it happen in Minnesota. And so the idea is that we're going to be expanding our reach within the school and bringing in some local experts about what that would actually look like. I've heard Senator Marty speak before. He's very great at helping us understand what's possible now, what's possible in the next couple of years, and what he's doing alongside other lawmakers to make that happen. So I'm optimistic that our action item in November will be contacting our local legislators on some type of legislation that Marty feels like is the most important immediate legislation for people to send emails out about. And I can build a template for that. The other goal I have is just I want the numbers to go up. I'm going to be telling people at the end of our October session that it's their job to bring a friend to our November session. And I think people will, really, because I think they'll have a good experience. And I want to continue giving MS1s opportunities to lead sessions. So I'm hoping that the kind of introduction and other little single pair one-on-one bits in November will be led by some of these MS1s that I've connected with. Yeah, that's what's going to be happening in November. And then I'm going to end the meeting by making sure that we've got a really clear transition for who the SNAP board of 2026 to 2027 is going to be. I know it seems like that's far in advance, but you'd be surprised how fast things move. And so it's just a good idea to get the ball rolling on that so that when myself and other students are going off on rotations, hopefully in March and April, we will have a very founded, already trained and capable SNAP board continuing to manage the school events on campus. And I want them to plan something in spring. I'm going to guide them in this process, but very intentionally, I want the second SNAP board to be the ones that have an opportunity to have an idea and put it into execution for our spring advocacy event. I would like to be more of a, by their side, helping them to find practical ways to accomplish their goals at that stage of the process. So that is our full trajectory for fall. These events are going to be really exciting, and I'm excited to see how Thursday goes. And while we're on the topic of action items, I'm sure many of you already have subscribed to these mailing lists, but if you haven't, I just want to leave on the screen 3 really, really important QR codes that you can scan that will keep you up to date on the fight for single payer here in Minnesota. It's as easy as pulling out the camera on your phone and pointing it at the QR code and then clicking on the link that pops up when you see it. So I'll leave this screen up so you have an opportunity to do that if you have not yet while I answer Dr. Crossan's question. Dr. Crossan.
Carson, thank you so much for particularly for reactivating SNAP. This is absolutely critical. We've got to keep SNAP going. It is, as you know, a very potent organization nationally and
Hmm.
will be very, very effective as we move forward to getting Minnesota or getting universal health care in the United States. The question I have for you is I was surprised by that other organization that has been working on getting universal health care. I had not heard about that before.
Hmm.
And the question I have for you, what's your sense of the percent or number of medical students who really are at least somewhat supportive of universal single payer? Would you like to make an
Yeah.
estimate?
Um, I have friends from a lot of different backgrounds in this first year program, and I think it looks a lot like our work at the state fair, where if you speak to somebody, no matter where they're from or what values they hold, they care deeply about the health of themselves, their family, and others, and they are concerned about waste in a way that is really significant. I'd say the vast majority of students that I've spoken to are supportive of the single payer concept. Now, when I say Medicare for all, sometimes they go, whoa. But if we actually speak about policy and we speak about data, I have yet to run into anyone who doesn't want the system to improve. I have run into students that are concerned about government management, in the same sense that I'm sure you have at the state fair. But there are people coming to this meeting on Thursday that I did not anticipate to RSVP. And that I think is pretty exciting because the the messaging is clear. This is an improvement, and people are allowed to have disagreements on what they want the improvement to be, but everyone agrees that our system right now is really dysfunctional. And it does not take someone who understands healthcare policy to understand that there are things that are really screwed up. So I think the state fair is the best metaphor. It's very similar in the medical class, I'd say percentages wise.
Great. Thanks very much.
Yeah. I'm just excited. It has been pretty easy to connect with students over single payer. I'm kind of known for single payer a little bit now because I keep bringing it up. I'm sure that you understand that. Um, and people are asking me very thoughtful questions about it that I feel prepared to answer. So it's a great representative that the internship program was very helpful and successful. Yeah, it's going to be a great fall and it's going to be a good legislative year, and we're going to keep our feet to the ground.
All right. Good evening, everyone.
Hi, my name is Maureen,
And my name is Nee.
and today we'll be talking about the Medicaid cuts and how it directly impacts HCMC.
Just a little bit of the history on HCMC. It was first established as a cottage hospital in 1871, with many changes over the years. It has evolved to become what we know of as the HCMC Clinic and Specialty Center today. As a safety net institution, HCMC serves a highly vulnerable patient population, including individuals who are uninsured, underinsured, and covered by Medicaid. The hospital provides care to nearly 200,000 patients each year, with half relying on Medicaid. HCMC faces ongoing financial challenges due to low Medicaid reimbursement rates and the high cost of uncompensated care. These financial pressures are expected to intensify with the proposed cuts to Medicaid funding.
And just a bit more about the HCMC patient population. So, HCMC provides care to all 87 counties, patients from all 87 counties in Minnesota, especially since it's a level one trauma center. A lot of patients from far from Minneapolis come and they're transferred over there to receive care. And then, as Nee mentioned, the hospital serves a diverse population. So, for example, 11.2% of patients are of the disabled population. And then, as you can see on the right, it kind of breaks down the diversity of HCMC. This data was taken from Hennepin Healthcare Community Need Assessment Report. The data was published in 2022, but the actual data is from 2016, was collected from 2016 to 2022, or 2020, sorry. And it shows that ACMC serves 40% of patients that identify as a race or ethnicity that is not white. And then as for poverty status, about 13.3% of your patients fall below the federal poverty level or line. And then as for languages, about 29% of their patients either do not speak English or have limited English proficiency. So now we'll be talking about the impacts of the Federal Reconciliation Bill on Minnesota. And the Federal Reconciliation Bill is the big, beautiful bill, quote unquote, just so people are aware. So with this bill going into effect, there'll be a lot of big funded custom Medicaids, and it will impact Minnesota directly. So, for example, Minnesota could lose up to $23.5 billion of federal funding for Medicaid over the next 10 years. And this equates to about 2.4 billion federal funding per year. So overall, that means that approximately 140,000 people could lose their health insurance.
Medicaid eligibility requirements are also expected to change. Enrollees will now be required to complete additional paperwork to maintain their current level of coverage, with eligibility checks occurring every 6 months instead of annually. These administrative changes will create procedural barriers, making it more challenging for people to sustain coverage. Increases in cost-sharing requirements will disproportionately affect low-income individuals, making it more difficult for them to access care. Particularly concerning is that refugees, torture survivors, and victims of human trafficking will be severely impacted by the implementation of these changes, as they will be restricted from receiving Medicaid coverage.
And how will the bill impact Minnesota's healthcare system? So right now, Minnesota hospitals and nursing homes sometimes do get paid more than Medicare rates for treating Medicaid patients. So this bill caps Medicaid payments so that they can be higher than what Medicare pays. And this will significantly reduce revenues for hospitals or nursing homes. And then another big change that we'll see is how we fund Medicaid in our state, Minnesota. So for example, Minnesota relies on what is called a provider tax. It's a way where we raise money locally and then bring in federal matching funds. But this bill restricts and even bans new provider tax. So this means that without this funding, hospitals could lose as much as $1 billion per year in the long run. Also, this bill cuts Medicaid funding. This bill will cut off Medicaid funding for certain hospitals, like Planned Parenthood, for a full year. So this means that there'll be fewer dollars for like things like family planning, STD testing, cancer screenings, and other preventative health services. And that especially impacts low-income Minnesotans who rely and depend heavily on these clinics for basic care. Right now, Medicaid can cover Medicaid bills up to 3 months prior to someone enrolling in Medicaid. So, for example, if someone enrolls in Medicaid, if someone had previous medical bills, and they did not realize they qualify for Medicaid and they enroll in Medicaid, Medicaid covers up to 3 months before they enrolled into the plan. But with this bill, that window is reduced. So now adults without children would only get 1 month of retroactive coverage, and then everyone else will get 2 months of retroactive coverage. And the result of this is that more patients will be stuck with medical bills or unpaid bills that the hospital will have to absorb. And then lastly, rural hospitals rely heavily on Medicaid patients, and with less funding and lower payments, many rural hospitals could face closures. So with all of this adding up, the impact is
I think we lost your volume.
Can you guys hear me?
Yeah.
Okay, great. I'm not quite sure where I stopped, but But pretty much to summarize this, when you add all of this up, the impact is clear. So fewer Minnesotans, there'll be fewer Minnesotans with healthcare coverage, higher out-of-pocket costs for low-income families, more people will have uncompensated care, and then greater financial strains on hospitals and clinics across the state. So what does this mean for HCMC? So as Nate mentioned early on, HCMC is facing a lot of financial challenges, especially since the pandemic. After the pandemic, many of your patients lost their Medicaid or private insurance. So currently 10% of your patient population are uninsured or underinsured, which is about 4% increase from 2022. Additionally, the hospital has lost $67 million in revenue compared to 2022. So with all of these financial losses, this has caused the Hennepin County Board of Commissioners to take over the hospital. And with the federal cuts going into effect, things are just going to get worse for HCMC. So HCMC is projected to lose up to $145 million per year in funding with the bill going into effect. And this will cause the hospital to make severe changes like staffing costs, cuts, or cuts to programs to compensate for the financial loss.
Like Maureen just previously mentioned, with the threats of funding cuts and potential closure, it is critical for us to consider the consequences of losing a safety net hospital like HCMC. As a direct result to closure, both clinical and non-clinical staff would face widespread unemployment, while surrounding hospitals would be burdened with the financial and logistical strain of absorbing a sudden influx of uninsured and underinsured patients. Access to emergency services and elective procedures will be more limited. Research has consistently shown that hospital closures would disproportionately harm patients in poorest health with the fewest resources. The impact of Medicaid cuts will extend beyond HCMC and affect entire communities and health systems. So rural hospitals in Minnesota will also be significantly affected by the proposed Medicaid cuts. These facilities often function as safety net hospitals for their communities, serving a high proportion of patients who rely on Medicaid for healthcare services. In fact, roughly half of Minnesota's Medicaid population lives in rural areas, making funding cuts particularly impactful in these regions. Reduced funding may force some facilities to downsize or close, resulting in longer wait times and extended travel times for patients seeking essential or emergency care. This graph here shows the distribution of healthcare providers in rural Minnesota. As we can see, aside from physical therapists and nurse practitioners, rural areas face shortages across nearly all specialties due to provider maldistribution. And right at the bottom, we can see that there is a pronounced shortage of physicians and mental health professionals. Cuts to Medicaid funding will only worsen these pre-existing disparities, further limiting access to care and contributing to poor health outcomes in rural communities.
So these data shows the estimated impacts of Medicaid cuts on Minnesotans. So for example, on the left, it shows that 153,000 people could become uninsured due to the Medicaid cuts. And then 166 to 495 people will die as a direct result of the Medicaid cuts. And then 32,910 people on average will not receive the medical care they needed in the last 6 months. And 26,825 people will not have received the medication they needed in the last 6 months. And then also 24,786 people will owe out-of-pocket expenses due to the Medicaid cuts. And then on the right, it just shows how preventative services will decrease just because people cannot afford to get these cares. So for example, cholesterol levels, blood pressure checks, sugar level checks, mammograms, pap smear, which are all very important preventative health care. These will all be reduced because people do not have insurance or coverage. And then at the bottom, it shows that there will be an increase in the amount of money people pay for out-of-pocket expenses.
So the overall impact on Minnesotans would be a significant loss of access to healthcare, like Maureen mentioned, particularly for our most vulnerable populations, including low-income individuals and people with disabilities. Reduced access to care is likely to drive an increase in health disparities and preventable deaths. Hospitals will face operational challenges, including staff reductions and worsening financial strain. And to offset these losses, we may also see cuts to public health programs, further weakening the healthcare safety net. Ultimately, patients will bear the consequence through longer wait times, higher costs, and reduced access to essential care.
So what are the proposed steps Minnesota will have to take to compensate for the Medicaid cuts? So they'll either have to decrease Medicaid eligibility, Medicaid benefits. They'll either have to reduce Medicaid reimbursement rates to providers, they'll have to either raise taxes, or they'll have to cut other state programs to compensate for the Medicaid loss cuts. And then what we prefer is for Minnesota to remove health insurance companies from financing our public health insurance programs. And we'll talk more about this with the PCC bill.
As medical students and PNHP interns this summer, we are advocating for the PCC bill, which would eliminate insurance company participation in the medical payment process. This legislation would empower the Minnesota Department of Human Services to directly reimburse doctors and hospitals for care provided through medical assistance and Minnesota Care. By streamlining payments, the PCC bill would mitigate the harm caused by Medicaid cuts and improve patient access to timely and affordable care.
So we all believe that healthcare is a human right. HCMC is also a very important hospital to Minnesota, as many Minnesotans rely on it to receive healthcare, especially the low-income, uninsured, and vulnerable population. Also, HCMC's mission is to partner with the community to provide quality care through medical education and research. And this hospital is very important to us as medical students, as majority of us do at least one of our rotations at HCMC. So to summarize, and what we'd like people to do is that through the efforts of the PCC bill, PNHP Minnesota, and national efforts, let's aim to preserve safety net hospitals like HCMC by continuing to advocate for single payer insurance. Thank you. That's it.
Thank you.
Wonderful. Does anyone have any questions for our presenters?
I'll chime in since nobody else is talking. I just want to thank you for that excellent review. And this is really critical. The hospital has been thought that it could close, and there are serious potential situations that could lead to the closure of this hospital, which would be devastating for the community. And of course, the hospital would not be having any financial problems at all if we had universal single payer healthcare, because the hospital, like all hospitals, would be on a global budget. And the central payer would pay the hospital based on the services that it provides. And I just want to point out that, as you all know, in late August, there were several mass shootings in Minneapolis. And what resulted from those mass shootings was that 16 critically ill mass shooting patients arrived at HCMC within about 12 hours. Now, the reality is that very few hospitals in the country could handle that, and probably none as successfully as HCMC did. And that is because that is a specialty of that institution. There is no other hospital in Minnesota that is as well prepared as HCMC is to handle those disasters. So thank you very much. This data is really critical for us to have as we move forward with trying to get universal single payer.
I'll just start on the title and then introduce Asif for us.
Yeah.
Our project is moving Minnesota Muslims to advocate for single payer healthcare. Both Asif and I are Muslim, and this was a particular project of interest to us. Living in the U.S., living in Minnesota, how do we move our own communities to this cause?
Yeah, so like Abdullah mentioned, the intent of this presentation is to be delivered to groups such as the Muslim Coalition or laymen or the layman general Muslim population within Minnesota, but also to move them not just to include universal healthcare on their agenda, not just in terms of the Minnesota health plan, but also in the long term at a national level, also have Medicare for all as part of their agenda, so that we can engage. And this presentation is going to be used to engage those Muslims and Muslim organizations to advocate and lobby for the inclusion of Minnesota Health Plan and Medicare for all as part of, the Senate bills that are presented at the state and national level. Next slide. So the way that we have kind of structured our presentation is sort of going for both emotional and logical arguments. So we start off with approaches to healthcare in the Islamic world, past and present, which is kind of giving a preview of what historically healthcare and medical provision has looked like in the Islamic world and how that ties or has similarities with single payer healthcare or universal healthcare in general. And then also talking about, then going on more to talk about general Islamic values, which are relevant to the current systems of healthcare delivery that we have, and how Islam's judicial legal stance on the current system, what is Islam's current stance on the current system, and how it supports the establishment of a universal healthcare system. And that's kind of also embedded in the examples that we show throughout history of how Muslim empires have kind of established universal healthcare practices. Next slide. So yeah, we start off with kind of conditions in pre-Islamic Arabia where before the advent of Islam, what kind of healthcare setting was prevalent in which the Prophet Muhammad came into as before the advent of Islam. So general health levels were considered poor and they were exacerbated by the harsh climate since like Saudi Arabia is extremely hot. And the common endemic diseases at the time were like things like leprosy, malaria, tuberculosis, and numerous other like eye and GI diseases, which is probably something that was also prevalent in other areas, but also was present in the Arab world at the time. And the practices, the surgical knowledge and practices were also limited, but also generally medical practices were limited. And there is in the literature, there is no evidence of like any oral or written treatise on any aspect of medicine at the time pre-Islam. There was some use of folk medicine, which also interestingly has some connections with magic. And that's the extent of what we could find in the literature. So post-prophethood, i.e., post like the advent of Islam and Prophet Muhammad declaring Islam as, the, I guess, latest Abrahamic religion on the block, he brought with him a tradition that heavily emphasized caring for the sick. One of his sayings, which we call hadith, is that no Muslim visits another sick Muslim in the morning, but that 70,000 angels will bless him until the evening. And similarly, if they visit a sick person in the evening, 70,000 angels will bless them until the morning, and he will reap the fruits of paradise. So this is kind of emphasizing the importance of visiting your sick neighbors or sick community members and the emphasis on how important health and healthcare is within the religion. The other hadith that we put down is that verily Allah sent down the disease and the cure, and for every disease He made a cure. So seek treatment, but do not seek treatment by the unlawful. So this is again moving on towards the emphasis on seeking care, but seeking care from people who are proficient in the provision of care. And that is something that was also very much emphasized by the Prophet during his time. Um, the other thing, another example that we thought we should include, which is quite relevant to single payer healthcare or not leaving anyone behind in terms of healthcare provision, was that during his time, the ruler of Egypt sent a physician to the Prophet as a gift just to take care of him and to be a personal physician for the Prophet himself. But the Prophet instead used him to treat all the people of Medina for free. So that's kind of the start of, a universal healthcare system where it's not just healthcare is not just for the VIPs or the people who can afford it, but sort of establishing the idea that if there's one physician in the community, he is not just going to be caring for me, but also for everyone within the city and within the community. The last thing on this slide is that during the Battle of Khandak, which is one of the earliest battles that the Muslims fought against the members of the Quraysh. In 627 AD, the Prophet directed Rufaidah al-Aslamiyah, who is said to be the first nurse from in Muslim history, to establish the first mobile care unit, which was essentially a tent to treat wounded soldiers. And this is sort of the first hospital, so to speak, that we see in Islamic history. And then again, kind of re-emphasizing the idea of medicine to take care to utilize healthcare from someone who practices medicine and is proficient in medicine. The Prophet also said that one of his famous quotes is that whoever practices medicine while not being known to be proficient in medicine is to be held accountable. So the idea here is again that we need to have people who are trained in medicine, who are practicing medicine. And this is one of the hadiths that kind of provide the impetus for Muslims to, establish the training of medical professionals in their communities so that they are provided with the best possible healthcare in their communities. So the first major hospital or like an actual hospital structure that we see was seen in the Abbasid period, and hospitals were called Bimaristans. Bimar is a word for sick, and stan basically means just a place for. So this was built in Baghdad, which is present-day Iraq, in 805 AD by the Caliph Harun al-Rashid. And this was the first free public hospital in Islamic history. So again, kind of highlighting the universal healthcare model. And during from like 918 to 981 AD, three more hospitals were built in the same city for healthcare provision for the community. One of the interesting things that we found is that Muslim hospitals like these Bimaristans kind of function very similar to how our modern hospitals work, and they also doubled as teaching institutions, where the Bimaristan that was built by the Caliph had 25 specialists, including like ophthalmologists and surgeons and bone setters, who also trained students using the hospital libraries and the hospital setting, so that care was not only being provided by the experts, but also apprentices were learning at the same time. And at the end, they were also like, after a certain amount of training period, they were also given diplomas so that they could work independently as well. All the hospitals that were established in the Abbasid period were secular. That means that Muslim, Christian, and Jewish doctors worked side by side to provide care, and the hospitals were also open to people from any kind of religious or ethnic background. Another big achievement during the Abbasid period, especially in the Baghdad area, was the establishment of the Bayt al-Hikmah, which was the House of Wisdom, which served as the royal library and had a lot of funding from the government, which was an important center of translation of Greek and Indian traditions of medical knowledge into Arabic so that people could learn from them as well and continue the tradition of innovation based on whatever medical knowledge had previously been established by experts from other areas. And some of the books that were published are also listed at the end. 10 dissertations on the eye, which was like kind of a encyclopedic knowledge of like whatever information they gathered about the eye, and then a bunch of other ones such as Firdaus al-Hikmah, the Paradise of Wisdom, and a lot of these were focused on medicine and healthcare provision. Moving on, this period also signified the golden age of Islamic medicine. And two of the biggest exemplars of the golden age of Islamic medicine are Al-Razi and Ibn Sina. So I'll talk about Al-Razi first in this slide, and then Ibn Sina, whose anglicized version of the name is Avicenna, and he's like, that's a pretty famous figure in medical history in general. So Al-Razi was the medical director of Baghdad's Bimaristan Al-Adudi, which was the biggest hospital in Baghdad. And he generally lived in relative poverty while charging patients nothing for treatment. So again, kind of going towards the model where healthcare provision was treated as more of a religious obligation, and the idea that Islam is proposing something which is similar to universal healthcare. He also wrote more than 200 books on medicine, philosophy, astronomy, and theology. He was trained in alchemy and learned music and then moved on to medicine later in his life. And some of the biggest innovations that he made or discoveries that he made during his time was he was the first to differentiate between smallpox and measles, and he wrote a book about it as well. He was also one of the first uh, people to use sutures made from animal guts for abdominal wounds, and also discovered the use of alcohol as an antiseptic, and was the founder of the first psychiatric ward within the Bimaristan al-Adudi that was present in Baghdad. In terms of his contribution specifically for healthcare for all, he wrote a book called Tibb al-Fukara, which was for one without a doctor. So this was dedicated mainly, or to be used mainly for people who could not afford to see a doctor or who were not close enough to a healthcare provider, and they could use this book as a reference to treat common symptoms such as like headaches, colds, coughs, and diseases of the eye, ear, and the stomach. So like anyone could use it, especially if they could not afford a doctor or were not close enough to a doctor. Yeah. And then Ibn Sina, who, like I said, is more famously known as Avicenna. He was called the Prince of Physicians, and he's probably, in terms of Islamic history, the most famous medical doctor that we know of. And some of the medical discoveries that he did was he was the first to describe guinea worm disease and a detailed anatomy of the eye, including 6 extrinsic muscles. Which also reminds me, Al-Razi was also one of the first people responsible of like studying cranial nerves in the brain and the spine, which I found really interesting. Anyway, moving on to the surgical contributions that Ibn Sina made, he described the intubation of the larynx and technique of tracheostomy and the operation of empyemas with a knife. However, the biggest contribution that he made to medicine was a book that he wrote, which was called The Canon of Medicine, which is a 1 million word encyclopedia which synthesizes Arabic medicine, including information that they translated from Greek literature and his own observations. This was also translated into Latin in the 12th century and became Europe's primary medical textbook between the 12th and the 17th centuries. It includes a therapeutic section listing 760 drugs, and in terms of his contribution or this book's contribution towards public health, Ibn Sina also advocated for the purification of water sources and the ventilation of living spaces to mitigate disease transmission. So this was kind of his way of starting to work towards a system of public health whereby people could begin preventative practices within their homes as well. And this is just a quote which I found in multiple sources and multiple texts, which says, "Medicine was born, Hippocrates created it. It was dead, Galen revived it. It was scattered, Al-Razi reassembled it. And it was imperfect, Ibn Sina perfected it." So this kind of just encapsulates the contributions of these renowned Muslims towards medicine and healthcare provision as we know it today.
Okay, I can talk about a case study of one of the examples of these hospitals. This is the Mansouri Hospital in 1284. And you can see at the bottom left the constitution that was kind of established in this hospital. So the duty of the hospital is to give care to the ill, the poor, men and women until they recover. And it's at the service of powerful and the weak, the poor and the rich, without demand for any form of payment, neither from those who are poor nor from those who are rich. And you can see the clear kind of Islamic messaging behind, only for the sake of God, the provider, that this was done with a religious intent behind it as well. So as far as the kind of care that is provided at this hospital, you see things like, separate wards for people who had fevers, those who had GI illnesses, those who had mental illnesses, the wounded, etc. And this hospital was said to have 8,000 beds at the time. There were wards that were separate for men and women, and they, had adequate female physicians and nurses that were staffing the wards for women. As far as cost, it was completely free. Patients didn't really, could stay without many time restrictions. It was funded with about 1 million dirhams per year of funding from the government and from annual, endowments. And the poor were, interestingly enough, discharged, not paying a bill, but quite the opposite, taking money home with them to care for their expenses while they were recovering before they could go back again to work. As far as amenities, you would see pharmacies, you'd see lecture halls, you'd see kitchens, and they would set about these, hospitals that the food was so good people would stay just for the food, and room for medical instruments. You'd also see, a mosque for the Muslims and a chapel for the Christians. So kind of, the idea of spiritual wellness as well. And here are kind of just two examples of some of the hospitals from the past, or what's left of them today. And you see that these were built very intentionally and very, with a lot of almost pride behind them. These were sanctuaries of healing. As far as financing of these hospitals, these huge institutions, they were financed mainly by the government or by charitable endowments set by the government or by other, philanthropic individuals. Like I said, treatment was free for everyone. The funds also supported the scholarship of students, allowing physicians to translate medical texts into advanced medicine. Patients would receive food, clothing, and sometimes stipends to kind of support themselves. And like Asif was saying, care was given regardless of religion, ethnicity, or social status. You see this document on the left side. This is like a document of that endowment establishing the purpose of this hospital. It's quite a fascinating read through. If we send it to you towards the end, take a look through this. It's pretty interesting. A present day example of single payer healthcare in the Muslim majority country would be Indonesia. In 2014, Indonesia saw that there was their healthcare system was kind of spiraling out of control as far as costs. They launched their national health program, and within a span of almost 10 years, it covered 260 million people, making it the largest single payer insurance system in the world. And you can see the impact that it had, reducing out of pocket expenses, lowering health expenditures, and just overall making a life easy for people. And this is a common theme throughout many other countries in the world, not just Indonesia. In 2018, this is a quote, that there were nearly 50,000 uninsured Americans that received care from a Muslim-run free clinic. And there are many of those even in Minnesota. And you get the idea that Muslims are really proud of this idea that medicine doesn't belong to one person, that medicine should be free for anyone who is not able to afford it. This is the second part of our presentation. So some general Islamic values that are relevant to systems of healthcare delivery. I'll go through these pretty quickly, and you'll see that these are, notes that are pretty commonly seen throughout different world religions, right? It's not necessarily completely unique to Islam, but Muslims like to see, their text being quoted, right? A lot of our religion is based off of, the backing of the texts. So in terms of protection of life, the Quran says, whoever saves one life, the reward of that is equal to saving all of mankind. As far as justice and access to care, the Quran mentions that stand firm for justice as witnesses for Allah, for God, even if it's against yourself. So the idea of what if I make less money under this system? What if my reimbursements go down for under the system? The idea that if it's a matter of justice, even if it goes against an advantage towards yourself, you still stand for it. The idea of caring for the community. The believers are like one body. If one part suffers, the whole body responds with sleeplessness and fever. The idea that you care for the poorest amongst you is not just of those who are at the top. As far as wealth equity, the Quran mentions that in the wealth of people was a recognized right for those who were needy and deprived. That other people also have a right to your money. Those who were not given as much as you were. And it's a test for you of whether or not you're going to give that money for them. The exploitation for profit. So there's a verse in the Quran that mentions that any gains in terms of wealth are meant for those who are poor, for those who are needy, for the travelers, and that the idea that wealth may not merely circulate among your rich, right? That the rich don't get richer, but that wealth is spread equally throughout society. And finally, removal of harm, and the obvious harm that comes from a system where people are not able to afford healthcare. The third and final part of this presentation is the idea of what does Islam say in terms of its judicial legal stance on the current system. This is very interesting. I wish I could have more time to go into this, but I'll go through it as quickly as possible. Conventional health insurance, as it is currently in the system, is actually not permissible for Muslims to participate in. It's this quote mentioned to here that it's similar to gambling, and there are a few other reasons that make it impermissible. But you see that scholars in America give a concession to Muslims here in America that hey, it's not the principle of this system is not permissible at all. But if you don't have health insurance, one doctor's visit and you could be in bankruptcy. That's not a feasible way to live life. So scholars do give concession. You see also the scholars give a permissibility for government health programs like Medicaid and Medicare. And the reasoning behind that is it's a government sponsored program, right? It's kind of just like a benefit from the government. There's not a concept of insurance in that. And then the third is the idea of exploring alternative options. And there's not much literature on this anywhere that I could find. Even when I spoke to some of my teachers, my Muslim teachers, they didn't have much that they could come up with either. But there's an interesting article that kind of just touches upon this idea that there's a group of people that are demanding universal healthcare. Is this something that Muslims should support or not? And it mentions that it could be considered a ma'ruf, which is like a good thing. And so the question is left, does this mean that Muslims should work for such a change that would relieve them from invoking that concession? So something for Muslims to think about is like, insurance is not permissible as it is. What are some alternatives to the system? I'll end with some next steps. One thing that we did already is that we sent a letter to a Islamic Jurisprudential Council, which issues verdicts for Muslims in terms of what's permissible and what's not. The letter was consisting of basically, this is what universal healthcare is. This is why, this is why we think it's not permissible to take part in regular insurance, and why we think single payer healthcare is the way to go. Is this something that Islam supports? And that would be a great source of motivation for Muslims to see that hey, this is what we should go towards. The next step is on October 11th. There's a Muslim State Power Summit, kind of held by Isaiah and the Muslim Coalition. The plan is to be there and to kind of share this voice of we want single payer healthcare. Eventually, the idea that me and Asif have is that we want to start polling Muslims on their attitudes and knowledge towards single payer healthcare. And we want to do these educational events at various mosques, teaching people what universal healthcare is in the first place. Have a panel with Muslim scholars, have a panel of doctors, have a panel of people who are involved in the field, and see how that makes an impact on this movement. This is kind of some parts of the letter, but I won't get into that right now. And that's all we had. Thank you so much, everyone, for your time.
My name is Gwen Powell. I'm an MPH PhD student in the Environmental and Occupational Program at the U of M. But my day job is that I'm a board certified professional interfaith chaplain, which is a big mouthful, but it basically means we serve everybody of all faiths or no faiths, just helping them make sense of the world and the context that they're in. And that particular context is Allina EMS. I'm solely dedicated to supporting the EMS staff rather than public facing, which is what a lot of chaplains do. So I support the EMTs, the medics, dispatchers, and all of our support staff, from the people who stock the trucks to those that fix the trucks and do computer stuff. My time is split between doing and running our wellness initiatives, like our peer support team, therapy dog program, our employee wellbeing committee, as well as doing one-on-one support with employees after calls. I'm going to talk about a pretty important aspect of developing and sustaining a single payer healthcare system in Minnesota. And that's thinking about how emergency medical services fits into it. EMS kind of sits in an unusual space of healthcare because it's kind of healthcare, but it's also kind of public safety. And because of that, living on the borderland, they often get forgotten. I'm hoping that if we can develop an appealing plan that considers the needs, find a significant ally within that population. This is just a quick snapshot of where we're going. Talk about the history of what's been going on in EMS, some of the challenges with incorporating EMS and recommendations. So there's just a couple of quick definitions that I want to throw out before I jump in. First of all, people use EMR, EMT, paramedic interchangeably, but they're actually different roles and they have a different scope of practice. EMTs can do basic life support, during narcotics, and complex assessment. I'm also going to mention that there are phrases BLS and ALS, which I sometimes say without thinking, and that just means either basic life support, which would be an ambulance with 2 EMTs, or advanced life support, which is paramedic on board. So what's going on? Why is it important to talk about this? Since 2020, the pandemic, there's been a gap in the rates of license lapses and new EMR, EMT, and paramedic certifications, yielding a growing deficit The deficit peaked in 2021, but it still hasn't recovered, and we're starting to see that separation again. 2020 also saw a significant decrease in call and run volumes, but after that, there's been a dramatic increase. And I'll show a graph in a second here, but St. Paul Fire Department reported nearly 50% increase in the last 10 years, with a lot of that occurring post-COVID, and that does not correspond with population growth. The good news is that this crisis affords us an opportunity. I'm always an optimist, and I like to think about ways that we can try to, bring something good out of dark times. So this is a really cool opportunity to gain the favor of some powerful stakeholders and fill gaps in creative ways that would really improve health. So here's this graph that I was mentioning, and it shows expired EMS certifications across all levels of care in the red compared to the new certifications. The majority of EMS clinicians that are leaving the field are under 40, and 50% are under 30. And now this poses a problem because EMS is a very physical job. And so as people get older, they tend to, leave the field naturally because of the physical demands of the job. And so to see younger people leaving at these high rates is really concerning. And then, as you know, another issue that relates to the unsustainability of our system is that we have an aging population. EMS calls are already up, and as the population ages, you can expect to see more calls related to particularly cardiac events and also falls and other injuries that are just related to the decline that happens. So when you pair the shortage of EMS clinicians with this increase in population, it's a crisis waiting to happen. I really like graphs, sorry. Here's another graph that just shows the severity of the shortage, because you can see that there's a big jump in calls following the pandemic. Now, it's not entirely clear if this is from the health losses that occurred during the pandemic, people just getting sicker because they weren't seeking primary care, or economic instability, which is growing. But my guess is that it's both. And there's not really, we haven't found a way to fix either of those things yet. And the really sad and difficult thing about this is that this is St. Paul, which is very well staffed and a well-paid service. Rural areas can expect to see increases on par or possibly worse due to the lower level of healthcare access there. Unfortunately, short staffing increases call times, which are already not great in rural areas. And as I'm sure you know, the statistics, with cardiac arrest, the first 3 minutes are incredibly vital. And when call times increase, people die. So we're going to talk about the why here. It's important to understand a little bit about the conditions that first responders are under to understand why this has gotten to this point. These folks are often seeing really gruesome scenes. They're entering bed bug infested hoarder homes. They're incredibly at risk for violence, getting punched, kicked, groped, and worse. We did a survey at Allina last year, and it showed that 90% of our clinicians have experienced violence of some kind in the previous 6 months, most of them multiple times. High call volumes means fewer breaks, fewer opportunities to rest, to go to the bathroom. It's pretty hard on the clinicians. Because of the shortage of medics, EMR and EMT can end up in situations that require them to manage situations beyond their scope of practice. And this is where moral injury comes in. We've had situations where we've got 20-year-old BLS, basic life support EMTs responding to severe accidents because all of our other resources were committed, and they didn't have the training appropriate to respond to that incident. And when things don't go as they should, whether it's because of what happened with EMTs or because it was just going to end up that way, it really hits them hard, especially given how often EMTs are very young. Emergency responders also aren't paid that well. Allina does pretty well. Minnesota does better than many, but considering the trauma and the physical risk, I'm sure many of you remember the Burnsville shooting where a tactical medic was killed. They should be getting hazard pay. They should be getting good pay, but many agencies are volunteer only. That said, there's a reason EMS is often an afterthought when people discuss healthcare, and that's because it's a really weird system and it's hard to figure out how you could incorporate it into single payer. There are some real challenges with this. So one of them is just the sheer complexity of the system. Every agency functions a little bit differently. Their reimbursement system is going to be a little bit different. The staffing, the maintenance, overhead, small operations are very efficient and inefficient, excuse me, and hard to maintain, while larger operations are easier to maintain. Some of them have good community partnerships. Some are kind of flying solo out in rural areas. Some have large service areas. Allina has multiple different service areas because we're such a large system, and we've got some bases like our Mounds View base and South Metro bases, which have incredibly high call volumes all the time. And then we have some that see 1 or 2 calls a day. And the metro operations really subsidize the rural operations because of the difference in the profit there. And that really results in a lot of people just saying, like, we don't know how to incorporate this weird system. We don't know what to do with it. That's somebody else's issue. Another issue is that the primary service area model that exists right now, it can kind of de-incentivize good service. And so even if response times increase, consumers can't really choose a different service in an emergency. So the organization isn't incentivized to improve the staffing or make operational changes that are going to benefit employee health and reduce the risk of moral injury. They're going to get reimbursed for the same calls regardless of how many people they have on staff, right? Lastly, a huge challenge, and one that we've seen a lot in the post George Floyd world, is that a lot of the prestige of the career is gone. People kind of say, like, oh, you're a first responder, you're a hero. But at the end of the day, they don't want to go into that field because they see that people are out there getting punched and kicked, and they're driving an ambulance through a blizzard while everybody else is safe in their home. It's a pretty tough job. It also doesn't have the same pension plans that public agencies do. So if you're in a private company like ours, you sometimes lose employees just to other agencies which have public pensions. So we really, really have to think about all of these challenges put together so that we can find a way to stop this attrition from the field, because it's really a healthcare risk. So that's a lot of challenges. As I was writing it, recognized, like, oh dear, we're in trouble. And have been seeing that in my work, of course. But I want to think a little bit creatively about how to address some of the challenges. So here are some recommendations that I have that's based on some of the literature, as well as some of the interesting creative things that are happening at some other agencies in the Twin Cities. So I don't know if any of you are familiar with community paramedicine, but these are really cool programs. And I think that incorporating community paramedicine universally into the EMS system as we fold into single payer could really be a big benefit. And of course, if this is something that improves the conditions in EMS because of reducing call volumes and lightening the load of severe calls, that's a way to get a foot in the door with a group of people who sometimes, often, frequently vote more on the conservative side. So I think there's some real opportunity in putting effort into this. You can take a look at these notes on my slide. Wilkinson and Stokes demonstrated that community paramedic programs reduce hospital admissions and frequent flyers. Allina piloted a program in the last couple of years, which unfortunately shut down for cost reasons, as we had to pull back a lot of our community programs. But our research scientists, Lori and Diana, did a cool study that showed that it reduced our call volumes in the 911 center by 25%, which is very significant. And dispatchers are often forgotten in this. We have our own medical dispatching group, and they're getting the trauma, the crying, the screaming on the phone and sending crews into dangerous situations. So there's like really high potential for moral injury and for distress and PTSD in that work as well. So seeing the downstream effects of improving the system, I think is worth noting. I mean, I think the bottom line on this is that EMS is a really cool thing. I get to do ride-alongs sometimes. Frequently, I get to do ride-alongs. And it's amazing what they do. And these folks are really dedicated. They're really smart. They're really great. We have a fleet of highly trained mobile clinicians. In rural areas where volumes tend to be fairly low, reimbursement is also low, which is a problem in for-profit systems. But there's a pilot up in Otter Tail County where they have a chase medic who follows their BLS crews in order to make sure that those, lower level of training clinicians have extra backup. But when they're not going on calls, they are going out into the community doing house calls, flu shots, blood pressure checks, blood sugar checks, looking at people's feet on diabetics, doing postpartum checks, and more. It's a really cool idea to envision having this extra workforce out in the community, really providing additional support for folks who don't have very good access to care because of being further away or, having mobility things that prevents them. My slide does not want to advance. Sorry. There we go. So a couple of years ago, North Memorial got a grant to pilot a community medic program. The grant was from Blue Cross Blue Shield in Minnesota. They wanted to see if this would reduce healthcare costs. No big surprise, they found that the medic program really did save money. In fact, for every dollar invested in the program, they saw about $11 of savings, according to the study, the follow-up study that they did. That's a really huge cost savings. It's also a huge reduction in 911 calls, which is a boon to an understaffed system. And we can't fix the understaffing right away because of the need to do education and recruitment. The study that I mentioned in the last slide that were completed by my coworkers, they also found that their community medic program really reduced the call volumes, but also increased the sense of community engagement. Because of the North program and others like it, Minnesota already has the legislative and operational infrastructure to go about this. There's no having to think about how licensure would work. There's already a licensure program in place. We know how to run them. North is a wonderful model for this. Hennepin Tech and Inver Grove Heights have community paramedic certifications. It's only 14 additional credits. This is something that could easily be folded into single payer healthcare bill to consider how we can either reimburse or just pay for tuition for these medics. Furthermore, now that we have telehealth, it's really easy to think about ways that you could incorporate EMTs into this program for more routine cares. A lot of folks who go into the ER for bumps and bruises, with a little bit more freedom and with telehealth, they may be able to prevent some of that overfill in the emergency department. So these are the recommendations that I have. I don't think North should be the only game in town. This program should exist really within every EMS service in Minnesota, in every area in Minnesota. We should be reimbursing tuition, like I mentioned. Particularly, we could think about ways that we can incentivize these students to stay in rural areas for a period of time. In my study of the Canadian system, I learned that various entities work under a blanket reimbursement program. Rather than messing around with insurance, private pay, under single payer, the entire organizational budget will be just made for a year, and whatever isn't met by federal funding will be folded into the state healthcare budget. Surplus or deficit will just be adjusted quarterly, depending on usage. This tremendously simplifies the current system and would remove a lot of overhead needs from EMS agencies as well. All right. This is a very complicated wheel, but I wanted to put it in here because I think it's important to think about the stakeholders that you engage and the benefit that that could have. As I mentioned, EMS they don't have a strong statewide union, but they often have strong unions. You may have seen Hennepin County Medical Center's union representative on the news recently after the Annunciation shooting. And so getting unions on board could be really meaningful. But also, healthcare and healthcare access, especially mental health access, really, really touches on something that is sensitive for police unions and fire unions, because they firsthand see the effects of folks that do not have access or who feel like there is stigma. And so they're often thinking about ways that they can incorporate more mental health care, more preventative health care into their own benefits packages. And so pulling these unions into conversations could bring a traditionally conservative group of folks into alignment with these ideas. I also think it's really important to talk to hospital administrators and EMS leaders, get them at the table to make it clear that this is going to relieve pressure on their systems, that the idea is to reduce unnecessary ED visits. And for private health systems like Galena and North, this could really net a lot of savings, as we saw in the study where, they were spending $1 and getting $11 in savings. But that's also, not even thinking about reducing the stress that these clinicians are facing when they're out on the street. I hear stories from folks where, they've been out to this house or this apartment multiple times, and this person doesn't have any supplies for checking their blood sugar. And this will go on for weeks, months, until they get that call back where this person has an infection, they're septic, they're going to the hospital, code 3, emergent, because this person is going to die if they don't get immediate care. And to be the clinician who has walked into this person's house multiple times and checked their blood sugar and talked to them and tried to counsel them but they know that this person doesn't have access, and the medic and the EMT can't do anything beyond take him to the hospital and then let him get sent home. That is moral injury, right? That's this overwhelming, I wanted to help and I couldn't help. And it's very heavy for them. So addressing these gaps in the healthcare system by enabling them to really do more and expand their scope, it would be a huge burden lifted for these folks. And that's really where my heart is with these folks, the young folks often, and helping them to feel like they are doing good in the world. The bottom line of all this is that a statewide community paramedic program benefits pretty much everyone. Reducing acuity and volumes helps EMS services and clinicians that are burned out. It also creates potential for career advancement by encouraging an additional certification and opening up new positions in program administration. It fills a serious care gap that exists in underserved areas. It reduces turnover, unnecessary hospital visits, as well as improving overall community health.
Some points of reference, and Carson already mentioned this, but similarly to him, rather than a more research-focused presentation, and of which all of the people who have talked today, I've learned so much. This has been such a great session. I'm really grateful to be here. But that being said, I chose to kind of do a similar thing of kind of restarting our Students for a National Health program. And I'm located on the University of Minnesota Duluth campus. So a little bit of a different population, a bit of different opportunities for students up here, and a bit of different kind of relevant background to discuss. So this shouldn't take super long, but I'll kind of get into providing a little bit more background. So some of you may or may not be familiar with the Duluth Medical School campus, but it's been around for quite a while now. And it is a smaller class than the Twin Cities campus, and we are up to now about 65 students per year. I think it's been about that number for a few decades now. So we have about a third of the class size than the Twin Cities campus. Obviously, our campus in general is a lot smaller. We're in a smaller city, so Duluth is like 85,000 or something compared to Minneapolis, St. Paul, which is, I don't know how big, but bigger. St. Louis County is technically a blue county, Blue-ish is what I said. But I think that's mainly due to the fact that Duluth is the main population center and relatively urban environment. But if you look at a map, and maybe I should put it up here, but St. Louis County is very large and encompasses a lot of rural country up north of Duluth. So that being said, and in regards to St. Louis County as well as Minnesota in general, the University of Minnesota Duluth's medical school was founded on the idea of providing primarily family care or primary care providers to rural Minnesota, as well as the indigenous population in Minnesota and nationwide. So that kind of changes our focus a little bit and gives us a little bit more perspective on those specific populations and what their specific needs may be. But it is of my opinion that, and I'm sure the opinion of most, if not everyone here now, that a single payer healthcare program would be extremely beneficial to both groups. And I mean, everyone generally speaking. But it has been kind of my goal to kind of focus on that mission and bring it underneath the scope of what Students for a National Health Program can offer and what a national health program means. And importantly, and why I said this was a timely mission on my title slide, is that the University of Minnesota Duluth's medical school is transitioning from a 2-year campus. So I'm in the 2-year campus class. I'm the last of that, to a 4-year campus starting with the current MS1s. So I'm the class of 2028, so I will still be moving down to Minneapolis this winter. But the new MS1s this year will be staying in Duluth for all 4 years. So they'll have a lot more opportunity for continuity, for community building, and for kind of building things out a little bit. So with that in mind as well, my goal was kind of getting things jump started, getting people interested, involved, and kind of, I'll be having to hand the reins over relatively soon. So just making sure that people are ready to take them when I'm ready to hand them over. So the timeline this far for this project of mine, of course, over the summer, had that wonderful internship with PNHP, which gave me the tools and the motivation to do this whole thing. So a huge shout out, of course, to Dr. Crossan and Jen, who are on the call now, and all the guest speakers who I've seen in the crowd as well. So thank you very much for all that. And then once school was starting up again, and in early September, I established SNAP as an official student organization. So that kind of was kind of just a lot of bureaucratic, annoying stuff that you have to do when you're setting up a student group. It was a student group that had previously existed in some capacity, although I'm not entirely sure in what capacity that is. When I was a student, so just starting last year, it didn't exist. So it was really kind of restarting it basically from scratch because of that. So restarting it from scratch, had a pretty early opportunity right away with an activity fair in September that is pretty well attended by students. That gave me the first opportunity to kind of recruit some first year students, especially. And luckily, I was provided with a lot of handouts. So thanks for PNHP for providing those. But it was actually I got a very surprising and very impressive interest turnout. So I mean, you can see the numbers down here, of course, but I got 17 responses on just kind of an emailed out Google interest form, and I got 19 signups at the activity fair itself. So all in all, I had 36 total interested students from a possible, I mean, I guess I didn't really reach out to MS2s as much, but it was a pretty impressive turnout, and I was really happy to see that so many people were interested in this mission and what this club could potentially offer. So that being said, the next kind of thoughts were, what do I do with these people now that I have them, now that they're maybe interested? What's next? And luckily, I stumbled into a very awesome opportunity that was already in the process of being set up by the Bioethics Club at UMD. And they had, unbeknownst to me prior to getting their email, managed to recruit Senator Marty to come talk about the Minnesota healthcare or the Minnesota health plan two medical students. So when I saw that, I was very excited, of course, and asked them if they would let me join for their session, and they were happy to have us. So I was able to kind of get that right away on the schedule. So this happened probably about a week and a half ago or so. And it was led by the UMD Bioethics Club as well as myself and SNAP. And we had an opportunity to learn about the Minnesota Health Plan and discuss it with Senator Marty himself. And this was just a really cool opportunity because just like myself prior to doing this internship, most students were completely unaware of like this bill and that it's kind of something that is something we need to consider in the near future. And it's super relevant for the mission of just SNAP and PNHP in general. And the outcome of this was more kind of interest brewed. Some people were there for the Bioethics Club invite and not for SNAP specifically. But because I was able to join in, I was able to kind of introduce this group as well. So the original 30, however, could potentially have grown to more. So that was a really cool thing to just get right into. But now it's kind of thinking about what's next. And right now, these are just ideas. I have created or I've reached out to some different people and I have different things in mind. And I'm really hoping to maybe hear some opinions from people in the crowd today, or if they want to shoot me an email or something afterwards, I'd be happy to talk about it there. But a few different events that I have not on the schedule, but in the planning is sort of a more specific what is SNAP conversation, what is PNHP conversation. So that is something I would hope to be able to host on my own. And I would love to have a guest joining us. I've not specifically reached out to anybody yet, but again, of course, I'm happy to hear from anyone here if they know of anyone who would maybe be interested and are potentially even in the Duluth area. It'd be really great to have someone local. Another event idea that I have is an advocacy starter pack is the name I've given it. So this is kind of a more direct action kind of thing where we can work in groups and teams and creating and workshopping sort of elevator pitches, which is an activity that we did this summer through the internship, building kind of conversation starters, kind of having answers to some common questions about, Medicare for all, single payer healthcare, just being able to, if you go to your family's Thanksgiving and you want to talk about this, how can you do that? What kind of questions should you expect to receive and what kind of answers can you provide? I think that would all be very valuable things to talk about while we're here in this environment. And I've also been keeping my eye out on joining different community efforts. So I have a few just like logos here. So there's like this Twin Ports DSA group that have a Medicare for All action team. I'm not exactly sure what that means yet, but I've reached out and I've kind of inquired about what kind of work they're doing in the area, if there's any opportunities for medical students to be engaged, if that's something that feels appropriate, as well as Healthcare for All Minnesota, which I'm sure many of you are familiar with. Through Twin Ports, they have some connections with Healthcare for All Minnesota, so that's also still something I'm trying to figure out. But definitely looking for some local organizing efforts to kind of put on the tail end of my time here in Duluth, and hopefully be able to kind of go out into the community and do something more active. And of course, I'm open to other ideas and hoping, that this is a very active and, it's a process that I'm working on now. So hoping to learn more from you guys and see what works, see what sticks. But like I mentioned, I will be done at UMD in December. So my main goal throughout this will be to have educated and inspired at least a few to continue this group within the new campus. Technically speaking, I only need to have one person who would be willing to become the president of this group. But I would hope that more than one would be interested. And then kind of begin to facilitate that transition to a new board and leadership group. So those conversations would have to be had with current MS1s, and kind of really it'd be my aim to kind of unpack what their goals would be now that they're on a 4-year campus and what they could do over a longer period of time. And of course, the goal would be to continue connecting with local advocacy groups. I believe that's everything on mine. Oh yeah, just some quick acknowledgements here. I think I kind of already said this already, but shout out everybody. And I guess that leaves us with a little bit of time for questions if anybody has any.